Kanski lecture series Eyelid part 6, and in this part we are going to discuss about the disorder of the eyelashes, misdirected lashes. So misdirected means that lashes are normally in a single row and are directed outwards, but in the case of misdirection there can be the problem in the direction of the lashes. Introduction. The roots of the eyelashes cilia lie against the interior surface of the tarsal plate. The cilia passes between the main part of the orbicularis oculi and its more superficial part, rheolan muscle, exiting the skin at the interior lid margins and the curving away from the globe. It is particularly important to be familiar with the normal anatomical appearance of the lid margin in order to be able to identify the cause of the eyelash misdirection from interior to posterior. So basically, the eyelashes are usually anterior to the tarsal plate, and they lie against the tarsal plate, but they are slightly anterior. So there is a cilia that contains the eyelashes, which is called the root of the eyelashes, and it passes between the orbicularis muscle and the superficial part of it, which is called the rheolan muscles, and it curves away from the eyelid, and this is how it is directed. So eyelashes cilia, the gray line by definition, the border between the interior lashes skin and orbicularis and the posterior tarsal plate and conjunctiva and lamellae. The meibomian gland orifice are located just interior to the mucocutaneous junction. The edges of the tarsal plate is deep to the gland orifice. The gland themselves run vertically within the tarsal plate. The mucocutaneous junction is where keratinized epithelium of the skin merges with the conjunctival mucous membrane. Conjunctiva lines the posterior margin of the lid. So basically it is showing the anatomy of the margin. So just consider that this is the interior part of the lashes and it is a posterior part of the lashes. Basically the lashes are eyelid margin is divided into interior lamellae and posterior lamellae. The interior lamellae and posterior lamellae are basically divided by the gray line. And what is contained in the interior lamellae and posterior lamellae? The interior lamellae consist of the skin and the orbicularis muscle, and the posterior lamellae consist of the tarsal plate and conjunctiva, and within the tarsal plate is basically the meibomian gland, and that is why the orifice lies in the tarsal. So this is like a skin, and then there is the lashes, which is called the cilia. Then there is a gray line, and then there is a meibomian gland orifices, which is deep to the tarsal plate, and then there will be the mucocutaneous junction. So this is how the anatomy of the eyelid margins. Clinical features. Trauma to the corneal epithelium may cause punctate epithelium erosions with ocular irritation often worsened by blinking. Corneal ulceration and painous formation may occur in severe cases. The clinical appearance varies with the cause. So anything which causes the trauma to the epithelium can cause the erosions of the cornea, and when the person blink, it is usually worsened. And the corneal ulceration and painous formation is basically the vascularization and infiltration that occurs with severe cases. The clinical appearances varies with the cause. So there are different pathologies that are associated with the lash follicles. There can be the trichiasis, there can be marginal entropion, there can be congenital dystrichiasis, acquired dystrichiasis, epiblepharon, and entropion. So number one is the trichiasis. The trichiasis is basically the misdirection of the lash. Basically, you know that the lash follicles are outward, but in case of the trichiasis, it is the lash follicles are lashes are directed inward, and this is called the trichiasis. Trichiasis refers to the misdirection of the growth from individual follicles rather than a more extensive inversion of the lid or a lid margin. So this basically this is the misdirection from the individual follicle. The follicle are at a anatomically normal size. It is commonly due to inflammation such as chronic blepharitis or herpes zoster ophthalmicus, but can also be caused by injury or by surgery such as incision and curettage of a lesion. So there are a number of causes that causes the trichiasis. So you can see figure 2.31, and in this it causes the misdirected lashes. A is showing that a single trichiatic lash. Single trichiatic lash means the lash which is should be like this is like inward. B is showing the ingrowth lash. C is showing the group of misdirected lashes secondary to chronic lid inflammation, and D is showing the acquired dystrichiasis. Next is the marginal entropion. So sometimes the trichiasis is not due to the follicle. The lid margins are not at normal position. For example, in case of an entropion, the margin is itself directed inward. So when the margin is itself directed inward, it causes the inversion of the misdirection of the lashes. So marginal entropion is one of the condition which causes the misdirected lashes. Marginal entropion has increasingly been recognized as a very common cause of eyelash misdirection secondary to the subtle cicatricial posterior lamellae shortens that rotates a segment of the interior margin towards the eye. The mucocutaneous junction migrates anteriorly and posterior lid margins become rounded rather than physiologically severe. Typically, numerous aligned lashes are involved. So what happened in case of the scarring? So whenever there is a scarring of something, the the portion which have a scarring causes the shortening of that area. So in case of an entropion, there is a shortening of the conjunctival or posterior lamellae. Whenever there is a shortening of that, it will causes the inversion of the eyelid. So that is how we got the misdirected lashes with an entropion. Congenital dystrichiasis. So basically dystrichiasis means that there will be the additional row of lashes instead of there will is a misdirection. There is a additional row of lashes. It is a rare condition that occur when a primary epithelial germ cell destined to differentiate into a meibomian gland develops instead into a complete pilosebaceous unit. The condition is frequently inherited in an autosomal dominant manner with a high penetrance but variable expressivity. The majority of the patient also manifest primary lymphedema of the legs, lymphedema dystrichiasis syndrome. A partial or a complete a second row of lashes is seen to emerge at or slightly behind the meibomian gland orifices. The aberrant lashes tend to be thinner and shorter than normal cilia and are often directed posteriorly. They are usually well tolerated during infancy and may not become symptomatic until the age of about 5 years. So in case of a congenital dystrichiasis, you know that a meibomian gland is a gland which lies within the tarsal plate in the posterior lamellae. So in a case of congenital dystrichiasis, what happened is that the glands which are to be differentiated into meibomian glands are differentiated into the lash follicles. So we will have an additional row of the lashes, but these lashes are usually shorter than the normal lashes and are very thin. So this is a congenital dystrichiasis, and sometimes it is also associated with the lymphedema of the legs, and there is a syndrome named lymphedema dystrichiasis syndrome. Acquired dystrichiasis is caused by the metaplasia of the meibomian gland into the hair follicle such that a variable number of lashes grow from the meibomian gland opening. The most important cause is intense conjunctival inflammation, for example, chemical injury, Stevens-Johnson syndrome, ocular cicatricial pemphigoid. In contrast to the congenital dystrichiasis, the cilia tends to be non-pigmented and stunted and are usually symptomatic. So in case of acquired dystrichiasis, it is not a congenital problem, but sometimes there is a metaplasia. Metaplasia is basically a condition in which the pattern of the epithelium changes. Like a gland which is directed to produce meibomian glands has started to produce the lashes, and it is caused by the intense conjunctival inflammations like chemical injury, SGS, and OCP. Epiblepharon is also a condition which causes the misdirected lashes, in which there is a fold of the skin, and which causes the inward rotation of the lashes. Entropion, in contrast to the marginal entropion, profound inversion of the substantial width of the lid is readily identified. See later. So, what is the treatment of that? Treatment is epilation with forceps is simple and effective, but recurrence within a few weeks is essentially very invariable. It can be used as a temporizing measure on an occasional patient who refuses or cannot tolerate surgery. So basically, epilation is done when there is a small number of trichiasis, or it can be done as a temporizing measure, and when the patient is symptomatic. Another procedure is electrolysis or electrocautery. Hyfurcation are broadly similar electrosurgical technique in which under local anesthesia a fine wire is passed down the hair follicle to ablate the lash. It is generally used for a limited number of lashes, but scarring can follow. Frequently, multiple treatments are required to obtain a satisfactory result. So, in case of the electrolysis, what we do is like, so for example, this is a lash follicle. We under local anesthesia, the wire is passed onto the hair follicle and they are ablated. And it is used for the when there are small number of misdirected lashes, but they can be repeated. This treatment can be repeated as well. Laser ablation is also useful for the treatment of limited number of aberrant eyelashes and is performed using a spot size of 50 micrometer, duration of 0.1 to 0.2 seconds, and a power of 800 to 1000 microwatt. The base of the lash is targeted and the shots are applied to create a crater that follows the axis of the follicle. Success is broadly comparable to that achieved with the electrosurgery. So in case of the laser, what you do is you select the settings. So settings are usually 50 micrometer. You have a laser size of 50 micrometer, and you use the power of 800 or 1000 megawatt microwatt, and you apply it for 1 to 2 seconds, and you apply it at the base of the lashes, and you ablate that lash follicles. So you can see figure 2.32. It is showing the appearance of the following laser ablation of the multiple lashes. Next is surgery. Tarsal fracture or transverse torsotomy is performed for marginal entropy. After placing a 4-0 traction suture, a horizontal incision is made through the tarsal plate via the conjunctiva, at least halfway down the plate, uh, along the affected length of the lid, and extended to 2 to 3 millimeter either side of the involved region. Depending on the extent of the lid involvement, either 2 or 3 double arm absorbable sutures are passed through the upper edge of the lower section of the tarsal plate to emerge just interior to the lashes, leaving the lid margin slightly everted. The sutures are left in place following the surgery. The occasionally short-term use of the bandage contact lens are required to prevent corneal abrading. A full thickness eyelid pentagon resection can be used for a focal group of aberrant lashes, typically after trauma or for a localized marginal entropion. Other options include lid splittings with CNEX with follicle excision and interior lamellar rotation surgery. So we can see the figure 2.33. It is showing the tarsal fracture for the repair of the marginal entropion. So what is a marginal entropion? Entropion can be involving the whole of the lid, but sometimes when only the margin of the lid eyelid margin is involved, it is called the marginal entropion. So what procedure can we do to prevent it? So you can see that what you do is you place a traction suture. So you evert the eyelid. For that, you place a traction suture and you evert the eyelid. And what you do is basically you incise the conjunctiva, and through the tarsal plate you divide the tarsal plate into the two. And after that you place the traction suture. And what is the placement of the traction suture? That you put the traction suture from the uh, 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 lower part of the upper end of the tarsal plate, and then it passes through the directly through the skin. So you can see this. And what it do is basically it evert the eyelid. A and B is showing the insertion of the everting suture following traction suture placement and a horizontal tarsal plate incision, and everting suture in place. And other procedures are we pentagon excision. We use the pentagon excision for the marginal entropion, as well as we can also do anterior lamellar rotation surgery. Cryotherapy applied externally to the skin just inferior to the base of the abnormal lashes, or especially in distal cases to the internal aspect of the interior lamellae of the lid, following the splitting of the lid margin at the gray line. Can be used for numerous lashes. A double freeze thaw cycle at minus 20 degrees Celsius is applied under local anesthesia, including adrenaline, with a plastic eye protector in place. Suturing of the lid margin is not usually necessary following splitting. The method is effective but carries a high rate of local adverse effect and is less commonly performed now in previous year. So you can see figure 2.34. Cryotherapy to the lid margin in distal cases: separation of the interior and the posterior lamellae. B. Application of the cryo probe to the posterior lamellae. So in case of a dystrichiasis, you know that the meibomian gland is producing the hair follicles as well. So in that case, what you do is, you have an interior lamella and posterior lamella, which is divided by the gray line, and you incise the lid margin from that area, and you divide the interior lamella and posterior lamella. And what you do is basically you place the cryotherapy. Cryotherapy is basically the freezing method. What you apply is a negative temperature, and when that negative temperature is applied, it causes the freezing of the cell and causes the cell death. So this is how the cryotherapy works. So you apply minus 20 degrees Celsius under local anesthesia, and you place the eye protector first. So you do it at the internal aspect of the interior lamellae, but in this case they are doing it in the posterior lamellae. They are placing at the tarsal plate. Eyelash ptosis. Eyelash ptosis refers to a downward sagging of the upper lid lashes. The condition may be idiopathic or associated with floppy eyelid syndrome, dermatoclasis, and with anterior lamellar slip or long-standing facial palsy. So lash ptosis is basically when there is a downward sagging of the eyelashes, like it's not everted, it's in a downward position. So this is called the eyelash ptosis. A is showing the eyelashes ptosis, and the causes are dermatoclasis, floppy eyelid syndrome, and facial nerve palsy. B is showing the trichomegaly. Trichomegaly is excessive eyelash growth. The main causes are listed in table 2.1. Basically, the eyelashes are at same position, but they are excessive growth of eyelashes, means there will be the long eyelashes. Madarosis is a term used for the loss of lashes. The main causes are shown in table 2.2. So these are important to know about the causes of the eyelashes disorders. And poliosis is a premature localized whitening of the hair, which may involve the eyelashes and the eyebrows. The main causes are shown in the table. So poliosis is basically the whitening of the eyelashes. Madarosis is the loss of eyelashes, and trichomegaly is an excessive growth. So just remember with the trichomegaly that there are certain medications that causes the trichomegaly. And one of the very important drug in ophthalmology is the prostaglandins that is used in the glaucoma. And other causes you have to remember, but the main is basically for the trichomegaly is the drug induced. So causes of trichomegaly is drug induced topical prostaglandin analog, phenytoin and cyclosporine. Malnutrition cause trichomegaly, AIDS, porphyria, hypothyroidism. Familial, which causes congenital. Oliver McFarlane, Cornelia DeLange, Goldstein, Hermansky, Pudlek syndrome. So these are some kinds of causes of the trichomegaly. Another is metarosis. So there are certain conditions that causes the losses of the eyelashes, and one of the very important is leprosy, that and some generalized skin disorders, and blepharitis can cause the loss of eyelashes. So local it cause, so in the cases of metarosis there can be local causes, skin disorders, systemic diseases and following removal. So local causes are chronic anterior lid margin diseases, infiltrating lid tumors, burns, radiotherapy or cryotherapy of the lid tumors. Skin disorders in which there is a generalized alopecia, psoriasis. Systemic disease, myxedema, SLE, acquired syphilis, lepromatous, leprosy. Following removal procedure for trichiasis, trichotillomania is a psychiatric disorder of the hair removal. Very interesting is that when you unknowingly start to remove your eyelashes, so this is a psychiatric disorder called a trichotillomania. So poliosis is basically the whitening of the skin. So any skin diseases which causes the whitening of the skin can also causes the whitening of the lashes, such as albinism can cause the poliosis, and VKH is another condition which is very important in eye, which can cause the this disease, and vitiligo can cause. So there are certain ocular causes and there are systemic causes. Ocular causes are the chronic anterior blepharitis, sympathetic ophthalmitis, idiopathic uveitis. Systemic causes are Vogt-Koyanagi-Harada syndrome, Waardenburg syndrome, vitiligo, Marfan syndrome and tuberous sclerosis. So that's it for the eyelid part 6. See you in the next lecture.